And I'm the executive director of the Northwest Parkinson's Foundation. We're the sponsor of this program, along with Parkinson's Resources of Spokane. And let's see, so for those of you who are not familiar with this program, the way it works is we have a guest speaker today, whom I will introduce shortly. And he'll be making a presentation. When that presentation is completed, we will actually go to 22 different sites that are participating in this telehealth program. So it's all done through broadcasting, and when we go to each of those sites, we have the opportunity for you to ask questions of the doctor, and the doctor will then respond to your questions. So for those of us here at the Evergreen room, we can participate as well, but we're going to be looking at this screen because that's what the remote participants are going to be seeing. So that's how this process works, and we're just delighted to have everyone here today. So let me go ahead and introduce our speaker. Dr. Ali Sami is an associate professor of neurology and adjunct associate professor of neurological surgery at the University of Washington. His presentation today will be an overview of treatment options for Parkinson's disease. Dr. Sami received his medical degree from McGill University in Montreal, and his clinical interests are in management of movement disorders with a focus on Parkinson's disease, dystonia, and tremor. So we're going to get started, and we'll have the PowerPoint. It should be up on all of the remote sites, and Dr. Sami will be using a pointer throughout the presentation. So until the talk is completed, we'll be back shortly.
All right, thank you. I hope everyone can hear me well. I'm hoping that you can see the pointer, although most of what I have to say is in written form, and I don't need to point too much. So I'm going to be covering a lot of different topics today. Covering the main drug for Parkinson's, carbidopa, levodopa. I'm going to be covering a class of drugs called the COMT inhibitors, which make up tolcapone and entacapone. Dopamine agonists, there's 4 of them I'll be talking about mostly today. And a few words about these 2 drugs, Rasagiline and Rasagiline, which belong to the category of medicines called monoamine oxidase B inhibitors. 1 slide on Amantadine. I'm going to say a few words about memory-enhancing drugs, which are used for dementia and forgetfulness. And also a few words about drugs we use for psychosis, for visual hallucinations and sleep disorders in Parkinson's disease. And just 1 slide on Coenzyme Q10. Everybody has questions about that. And then I'll end with a few slides on deep brain stimulation surgery for Parkinson's disease. And because 2 months ago, or close to 3 months ago now, the DOPA scan was approved, FDA approved in Parkinson's disease diagnosis, I'll say a few words about that as well. So going back and trying to review some history as to when we realized what we now know is happening in Parkinson's, it goes back to, well, James Parkinson wrote his famous essay on the shaking palsy back in 1817 is when he published it. And as you know, Charcot, the famous French neurologist, named the disease 45 years later after James Parkinson. But it wasn't until the 1950s, actually the late 1950s, when we realized that the motor problem Parkinson's, the mobility issues, the tremor, and the rigidity in Parkinson's disease are related to the drop in dopamine cells in the brain, in the midbrain, the ones that send dopamine projections to the top of the brain, to the basal ganglia, are going bad in Parkinson's. It was 1957, 58 when this was discovered by Hornikowitz, Austrian physician, and his group, and elsewhere duplicated the data. And the first use of levodopa was in 1961 without carbidopa. That's when it was first used in a human being. By 1966 and 1967, levodopa was being widely used, again without carbidopa, to help patients with Parkinson's disease. And that's sort of the theme of the movie Awakenings, which is the discovery of levodopa and how it revolutionized the way we treat Parkinson's disease. When carbidopa came along in 1972, they call this medication Sinemet. Sin means without, MSS means nausea. Because levodopa alone caused a lot of nausea, they call this combination carbidopa-levodopa without nausea. It allowed us to use a much lower dose of levodopa in terms of reducing it from, let's say, 3, 4, 5 grams of this stuff down to, let's say, a few hundred milligrams of levodopa when you add a small amount of carbidopa. So carbidopa is a very smart designer drug in that it blocks the absorption, it blocks the conversion of levodopa to dopamine in the serum outside the brain. So it allows levodopa, more levodopa, to cross the blood-brain barrier to become basically dopamine inside the brain when you want that conversion to happen. You don't want levodopa to become dopamine outside the brain because dopamine itself does not cross the blood-brain barrier. So by blocking the conversion of levodopa to dopamine outside the brain, which is what carbidopa does, you let more levodopa get into the brain, and it's the dopamine outside the brain that causes nausea. That's why the first thing that happened when carbidopa came along is that it stopped people from puking when they were taking this stuff for Parkinson's. When I was a resident in 1991 is when Sinemet CR came out, and later on all these drugs came out, and we'll talk about some of these, and we'll talk about the liver problems with tolcapone that was discovered in 1998. Now, as you know, Stalevo has been around since 2003, which is a combination of entacapone, carbidopa, levodopa, all in one pill. And a year later, this formulation came around called the Parcopa, which is basically carbidopa, levodopa in a form that melts in your mouth, but still has to go through the gut to be absorbed. So it comes in various doses. It's still the best drug we have. It's still the most effective drug, I should say, we have in terms of the bang you get for your buck in terms of motor improvement, carbidopa, levodopa. After 45 years of treatment for Parkinson's, it's still the most effective and the most potent drug we have for Parkinson's disease. It comes in various ratios of carbidopa to levodopa. So the first number here is carbidopa milligrams, and the second number is the levodopa milligrams. And it comes in regular or controlled release versions. So CR stands for controlled release. You see two other abbreviations here. It could be ER for extended release, or SA, which is slow acting. So we have the SA form at the VA hospital, and it basically means slow acting. But they're all pretty much the same in that once absorbed, the levodopa in your system has a half-life of only 90 minutes. But what the CR formulation does is it allows the absorption rate to slow down, so it takes a bit longer for it to peak, and it kind of lasts a bit longer in your serum. But so the CR is a slight advantage over the regular in terms of longevity, but the drawback is that the CR is 30% less bioavailable. That is, the levodopa, which is the second number here, the levodopa in the controlled release version of carbidopa levodopa, Sinemet, is about 30% less well absorbed in the controlled release version compared to the regular release version. So you have to take that into account. So when you switch from one formulation of carbidopa levodopa, let's say from regular release to the controlled release, you have to take that 30% and you have to increase the dose by that much. In the opposite direction, if you're taking controlled release and you have to have surgery done, you go to the operating room, you come out, and they have an NG tube in your nose and they have to give you the medication. They have to take this into account. If they crush this stuff and give it to you, it'll become regular release and you become toxic on it because you're getting 30% more. So they have to be aware of this in both directions. There are many different generic versions of these pills available. There are some good and maybe not some so good. So you might see a little difference when you switch from one generic version to the next. The regular release ones are generally pretty much very, standard, very good. There was one or two versions of the controlled release which didn't work very well, so we had to get rid of them. And I haven't seen them in a while, actually. So you wonder why there are various degrees and ratios between the two. The reason is that too much carbidopa is not supposed to cross the blood-brain barrier. So carbidopa is not supposed to block the conversion of levodopa to dopamine inside the brain. It's supposed to do that only outside the brain, so more levodopa gets into the brain where you want it to become dopamine. If you give too much carbidopa, a high dose of it actually by osmosis gets into the brain. So when you are using large amounts of levodopa in the 2 or 3 gram range, then you switch to the 1 to 10 ratio. So you use a smaller ratio of carbidopa to levodopa to reduce the amount of carbidopa getting across the blood-brain barrier so that it can still do what it's supposed to be doing without blocking levodopa becoming dopamine inside the brain. So that's the reason for various ratios. But the most common pill is 25-100, which is the yellow round pill. And the most common CR is the 5200, which is usually a purple-gray oval-shaped pill. So levodopa has a short half-life. That's the main drawback of only a half-life of 90 minutes. So after many years of use, or even sometimes after a few months of use, it can cause what we call end-of-dose wearing off, which is the most common motor fluctuation. Fluctuations are those ups and downs in mobility, in the degree to which the drug is working in you. And an off state is when you feel the drug is not working in you at that moment in time. An on state is when the drug is working and you're mobile and you're less shaky and less rigid. And so these transitions between off and on states are called fluctuations. And the most common one is this one, end of dose wearing off type of fluctuation. Dyskinesias are those fidgety, squirmy movements that Michael J. Fox has when you see him on television. And a lot of people, especially young onset Parkinson patients who take large amounts of carbidopa, levodopa, start getting dyskinesias earlier than they should. They start having those fidgety movements, usually up to a third or more have it at 5 years, and a lot of people, most of them after 10 years have it. You see it less in older folks, and you're seeing it less now because we are using other drugs in addition to levodopa with Parkinson's disease patients. So I think that these numbers probably reflect what we saw 10 years ago. It's probably less than that because we're using adjunct therapy, but nevertheless that's something to watch out for and something for us to want to delay the use of carbidopa, levodopa until it's something that we use as second or third or fourth line drug in people. So it does cause some blood pressure drop, it does cause some dizziness, and it can cause some drowsiness, but not as much as agonists do, and it causes dyskinesia. So for the most part, it's well tolerated. It doesn't cause too many side effects. I want to go over a study with you done on levodopa because everybody thought levodopa was bad for you. We shouldn't really start it in most patients, and it may do some harm. So there was a study done by Stanley Fawn. It was published in late 2004 in the New England Journal of Medicine. And what they did is they randomized people to getting placebo or multiple doses of carbidopa, levodopa over a 9-month period. So these are folks who have just been diagnosed with Parkinson's disease. They have not been taking anything else for Parkinson's disease. They get randomized to 40 weeks of the real drug at various doses versus placebo. And then what happens at the end of the 9-month period, they wash them out. They stop the medications cold turkey, and they see what they look like in the ensuing 2 to 4 weeks. So what happened is that people who were on Cinemet, who were on carbidopa, levodopa, did better. Their motor scores were better, they were more mobile, they were shaking less. And when you stop the medication, they all get worse, but they never go back to being as bad as the ones who had been on placebo, who had been on nothing for the first 9 months. So that suggests that there's some kind of a long duration effect from this medication, or maybe it slows progression of disease, or has a long-lasting effect on symptoms beyond the half-life and also beyond the 2 to 4 week washout. So here's the graph of that study. This summarizes what happened. So the higher scores are worse, the lower scores are better. So you put people, this is time 0, these are de novo patients, newly diagnosed Parkinson patients who get randomized to either getting the placebo or 3 different doses of carbidopa, levodopa. So this is the total daily levodopa milligrams. So this is like taking the 25/100, 2 tablets 3 times daily, 1 tablet 3 times daily, half a tablet 3 times daily. So the higher the dose, the better people do. The lower their motor scores. A nice dose response curve here. The middle dose gives you a mid-range benefit, and the lower dose gives you benefit over placebo, which is still significant. So then they stop the drug. They stop the drug at the 40-week mark, and then they monitor them for 2 to 4 weeks, and the scores go back up. Even in this group, they go up a little bit. Here, they go up more, but they all huddle right around this area. That means they never go back to being as bad as the ones who had been on nothing for the entire 9 months. Although the half-life of this drug is only 90 minutes, there is clearly some prolonged benefit. There is clearly some long duration benefit from levodopa, or perhaps something more. Again, suggesting that it's probably, if you delay treatment in Parkinson's disease, in early Parkinson's disease, to the point of not treating folks when they probably should be treated for 9 months, they have a worse outcome. So I'm going to move on to COMT inhibitors, a new class of drugs. So before I go on, this theme of starting people earlier rather than later on something is becoming more popular. And I personally do not wait till the patient is disabled before starting them on something. It doesn't have to be carbidopa, levodopa. It can be some other thing. But I tend to start people fairly quickly on anti-Parkinson medications and not wait too long. So COMT inhibitors basically are inhibitors of this enzyme, catechol-O-methyltransferase, which is an enzyme that breaks down levodopa. So by blocking an enzyme that breaks down levodopa...
For conference chairperson services, press the pound key. All other participants, please wait.
Is that for me?
You are the first person to join the conference. For conference chairperson services, press the pound key. All other participants, please wait.
So what should we do?
I just keep going.
Enough notes here in case we don't hear any more of it.
Okay. Let me zoom out.
Sorry about that, Kirkland. I think we're back
We're talking now.
with the audio corrected. If you want to continue with the presentation.
Is that loud enough for everyone?
Shall we use the volume again?
How's that? See what it does.
A second.
There's next. There's back.
Good afternoon, telehealth assistant.
Oh, no, that's good. COMT inhibitor.
Scenario going on here with
For our participant there in Kirkland, I think we're ready to continue if you can hear us.
So you've got the sound.
Should I, no, I'm sorry, this was
Great.
2.1, right?
University of Scientific Everything.
I want to save it. Oh, we don't want that. I wanted it to be unzoomed, and I wanted it to be a little higher so that they can see the screen better.
No offense, but they shouldn't use that color.
The yellow's a little hard to read.
Okay, good. Should I continue with COMT inhibitors?
Yes, please, sir. I think we're
All right,
ready to go ahead.
everyone hopefully can. So, as I said, the COMT inhibitors, that stands for catechol O-methyltransferase, and these two compounds, tolcapone and entacapone, are basically, they belong to this category of
For
medicine.
conference chairperson services, press the pound key. All other participants, please
All right.
wait.
I'm not going to press anything else anymore. So, I'm only going to press, 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 I'm only going to
okay, 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 okay,
Whoa. Is that what you've been getting?
Yes.
I've never heard that before.
That's what Spokane said too.
I've heard it outside in the dark, but never inside.
Speech owls.
Spokane almost has to disconnect too.
They said they were gonna do that.
Were they?
They said they've never.
Now we've got a mini light show going on.
Oh, is that not under your control?
No, 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 we don't. I mean,
Good afternoon, this
somebody
is
else-
Tammy at Northwest Telehealth. Thank you everyone so much for your patience with our audio issue. It looks like we've narrowed it down to the North Idaho sites. So we've disconnected them momentarily. We're not sure if we can add them back in.
Tammy at all?
But what we would like to do is go ahead and get started with the presentation and not disrupt the conference for everybody else involved. Dawn, can you hear me in Evergreen?
we hear you fine.
Okay, thank you so much for dialing back into the bridge. I don't think, if anybody's hearing a funny sound right now, just please unmute your microphone and let us know. On our bridge right now, it's quiet and it seems like it's good. So if you don't have a problem and it sounds good, don't respond. But if anybody hears anything funny, just go ahead and unmute your microphone and let us know.
So, but I don't see this, our screen. That's not our slide, is it?
No, we're still seeing your telehealth.
Yeah, sorry,
It's
here,
okay. No, that's fine.
Is that Spokane?
you can look at me.
Hey, Tammy. Hi.
So, okay, I didn't hear anybody else come back on, so we'll just go ahead and mute our microphone here at Telehealth. We'll monitor this a little bit further, and then at least let you guys get going with the program again, so we're not wasting any more time. And again, we apologize for the interruption.
Thank you. So COMT inhibitors have been around since the late 1990s, and COMT came out a little, actually Tolcapone came out first by a few months, and then Entacapone came out after that. So the usual dose of Entacapone is 200 milligrams used with each dose of carbidopa, levodopa up to 6 times a day. Usually beyond that, it doesn't do any good. And these COMT inhibitors basically block this enzyme which breaks down levodopa. Thereby, they increase the duration of action of levodopa and make it last longer in your system. So it's mostly used to help alleviate the end of dose wearing off that people get with carbidopa, levodopa. So as of 2004, 2003, Stalevo came out, which is a combination of carbidopa, levodopa, and entacapone all in one pill. And it comes in 6 or 7 different doses. The dose of entacapone is the same. It's just that the dose of carbidopa, levodopa is different from dose to dose to give variety to patients. As you know, the main side effect, which is quite visible, is this bright orange discoloration of the urine, and about 5% of people get diarrhea from it. Again, when you take COMT inhibitors on top of the Sinemet, it can exacerbate all of levodopa's side effects, including dyskinesias. So, now Tasmar is the one that came out a little earlier by a few months, but after about a year or two of using this drug called Tolcapone, they realized that some people got liver damage. It was a very small number of people. Out of about 40,000 years of patient use, that is, let's say, 40,000 patients using it for a year or so, there were 9 cases of fulminant liver failure and 3 patients died. So in 1998, it was briefly pulled off the market, actually not in this country, but elsewhere, and all kinds of severe guidelines in terms of managing the liver enzyme monitoring is now being done. The usual dose is now 100 milligrams 3 times a day. I have very few people on it, and I let their primary care doctors monitor the liver enzymes. So moving on to a different class of drugs that we use for Parkinson's, the dopamine agonists. The agonists have been around since 1974. My old boss and my old mentor, Donald Kahn, was one of the discoverers of bromocriptine in 1974. This is an ergot-derived dopamine agonist, which is still in use in many countries. We hardly ever use that in this country now. Then came out pergolide, which was actually pulled off the market in 2007 because we realized it causes heart valve problems. Bromocriptine is also these are both ergot-derived dopamine agonists, so they cause fibrosis. They cause scarring of various body tissues, including the lung, the belly, and the heart. So this is one reason pergolide, being more potent, was pulled off the market. These 2 drugs, Requip and Mirapex, came out in 1997 within a few months of one another, and they're still available. Obviously, we use them in generic form, and ropinirole became generic in 2008, and pioglitazone in 2009. So now they're cheaper and readily available. And they're not ergot-derived, so they don't have the same side effects in terms of causing heart valve disease that pergolide did. This drug is an old injectable drug that's been around for decades, but in this country we've had it since 2004 as a rescue drug. I'll tell you a few words about it later. The Neupro patch was only on the market for less than a year. It's a dopamine agonist patch, which you put on, it's transdermally absorbed, but it was pulled off the market because of crystal formation within the patch, which kept the drug from being absorbed well. It'll come back probably next year, so look for it coming back in 2012. That's what the drug company tells us. And as you know, Requip XL and the Mirapex ER now are both available as of a year ago or 2 years ago. So they also tend to be less potent than levodopa, but more potent than Rasagiline and Rasagiline, which are the MAO-B inhibitors. So they are mid-potency drugs in terms of class effect. The side effects are numerous. They do cause some nausea, they do cause some low blood pressure and dizziness. Some of the side effects which are more pronounced with agonists compared to levodopa is that they cause more drowsiness. They cause sleep attacks, rarely, but they do cause sleep attacks. They cause hallucinations, mostly visual hallucinations and paranoia and psychosis, more so than levodopa. And one of the big hot topics is impulse control disorder, which was first detected as compulsive gambling. Now we know that it can show itself in many other ways, including hypersexuality and activities, disinhibited activities like being infatuated with certain activity, internet, writing your own biography, or substance abuse and too much eating and erratic investing and things like that. So it can show itself in so many different ways. But the big ones are compulsive gambling and hypersexuality and too much eating and shopping. So these are not gut-derived agonists. They've been around since 1997. They're used, FDA approved, for both early and advanced Parkinson's disease. They cause less dyskinesia than Sinemet does, and they allow for a lower dose of Sinemet to be used. Now, Mirapex is more potent than Requip, and the usual conversion dose between one to the other is 1 to 4. So a milligram of pramipexole is equal to about 4 of ropinirole. So if you're being switched from one to the other, they have to take that generally accepted conversion ratio. And they're both available in generic, and they're both available in more brand name, expensive, once daily use, Mirapex ER and Requip XL. A lot of people, they really haven't caught on, in part because they're very expensive, and in part because they may not provide a whole lot of advantages. I tend to use these once daily drugs in early Parkinson's when the patient's taking, let's say, once daily Azilect, and they're comfortable just with once daily dosing of their drug. They don't want to take medicines 3 or 4 times a day. And also in more advanced Parkinson's disease, people who have side effects with peak dose effects of these drugs. So if they have peak dose nausea or peak dose drowsiness from generic regular release pramipexole or ropinirole, I may switch them to Mirapex ER or Requip XL to avoid that peak dose side effect that they have. So that's the usual situation where I may use these drugs. A few words on Apokin, apomorphine injection. So apomorphine is an old drug. The structure of this compound has been known since the 1800s. It was first used in the early 1950s in a haphazard form. They realized that it actually helps Parkinson's disease patients. This is many, many years before we even detected that Parkinson's disease was due to dopamine deficiency syndrome. Because apomorphine is a very potent nausea-causing drug, it is sometimes used, and it's still used in some vet hospitals, to make you puke, to bring up what you had swallowed and stuff. And I think this is the way that this was discovered to be a useful drug in Parkinson's disease. Now, it's best absorbed through this route. If you give it intravenously, it can cause some inflammation of the veins. So it is mostly a subcutaneous injection drug, and it's like insulin, it's giving yourself an insulin shot. We have about a dozen patients on this medication as a rescue drug. It is meant to work very quickly within 10 or 20 minutes to rescue a Parkinson patient from a severe off period or from a no on period, which is when you take your Sinemet dose and you expect it to work in an hour, it doesn't work at all. It doesn't get absorbed. So this bypasses the gut, gets into the system, gets into the brain rapidly, and starts to make the rigidity, the tremor, and the symptoms of Parkinson's better over 10 to 20 minutes. It only lasts about an hour to an hour and a half. Then it dissipates. So it is meant to only rescue you from a severe off period until something else like your oral drug Sinemet begins to work. So it is that situation that we tend to use it in. Again, because nausea is a major issue, you have to premedicate yourself with Tigan, trimethylbenzamide, for 3 days before even getting your first test injection in the clinic. So the first dose is injected in the doctor's office, being monitored for blood pressure and nausea, things like that. And if you do okay, then you can start taking it at home and self-injecting yourself. Frequently, we have a loved one, a family member or caregiver learn how to use this, because when the patient is off, they may not be to handle the injection themselves. So it's frequently given by a caregiver. A few words about the Neupro patch. It is not available now. It was for about a year, a couple of years ago, pulled off the market in 2008. But it's supposed to give you this continuous dopaminergic stimulation using a patch that you put on in the morning and you remove the following morning by replacing the patch. And it's used for Parkinson's disease, FDA approved, but it was pulled off the market voluntarily because some crystals began to show themselves within the patch. So the FDA was concerned about the Rotigotine molecule, the active ingredient, not being absorbed through the skin, and the company pulled it off the market by itself voluntarily, and it's going to come back probably in 2012, they tell me. And
Better now.
okay. I won't answer that call. I'm afraid that something bad might happen. So I don't want to be repossessed by demons again. So Rasagiline, going on to a different class. So we've covered carbidopa, levodopa. We've covered the COMT inhibitors, agonists. Now we're moving on to MAOB inhibitors. Rasagiline being the oldest one that we still have available. So this is a MAOB inhibitor. This blocks one of the enzymes, MAOB, which breaks down dopamine. So by blocking an enzyme that breaks down dopamine, you enhance the levels of dopamine inside the brain. So that's how this drug works, by enhancing dopamine levels inside your brain. It's been around since the 1980s. The first study with it came out around 1990. The very famous DataTop study was published in 1993. And it basically suggested that this drug may actually be, quote, neuroprotective. Now we know that we have no way to prove that, and it provides some symptomatic benefits. So this is the reason why it delayed the need for Sinemet in that earlier study. So it does provide some improvement in symptoms merely because it raises dopamine levels by a small amount. It has some amphetamine byproducts. The usual dose is 5 milligrams twice daily, but because of the stimulant byproducts, the second dose should be no later than noon because it might keep you awake at nighttime. And there's a study published in 2006 by the Swedish Parkinson study group where they randomized people to Rasagiline versus placebo, and they randomized and they followed them for 7 years, for 6.5 years. And I'll show you the results of that. So this was a study when they randomized, this is de novo patients, Parkinson patients, not on anything else. They randomized them to getting placebo versus Rasagiline. And then they followed them until they need Sinemet, until they need carbidopa, levodopa, which was about 5 months in placebo takers and 13 months in the Rasagiline takers. So it did delay, again, the need for Sinemet by about 8 months in those patients, something we knew already from the earlier DataTop study. But what happened is that once they started taking Sinemet, these graphs began to separate. That is, despite the fact that Sinemet obviously plummets these scores, the lower scores are better. Levodopa helps them move better and shake less and be less rigid, so these scores drop. But over the 6.5 years of follow-up, Rasagiline takers continue to do better compared to the ones on placebo. Now remember, these are people who are taking carbidopa, levodopa on top of the Rasagiline or placebo. And the end point of the study for them was the time that they needed a third drug, let's say a dopamine agonist. But this entire group stayed on placebo the whole time without getting Rasagiline, and these scores began to separate in that people who had been on Rasagiline at all of these time points did better in terms of their scores compared to the placebo takers. So they thought maybe this has something to do with the fact that Rasagiline allows a lower, medication, allows some dopamine enhancements, so you can actually, have used variable doses of Sinemet. And they thought that maybe this group did better because they were taking higher Sinemet doses than that group. But it turns out, no, that was not the case. In fact, the group of people taking Rasagiline was using about 150 or 200 milligrams less levodopa compared to that group. So that doesn't explain it. Again, this is another theory that these drugs may have something beyond their symptomatic benefit and maybe some disease-modifying capabilities. But still, to this point, we don't have a definitive answer as to whether these drugs, let's say Rasagiline or Rasagiline, clearly modify the disease for the better. Moving on to the next MAOB inhibitor, Rasagiline, has been around since 2006. It's used once daily, FDA approved for both early disease and late Parkinson's on top of Sinemet. One big randomized, well-publicized study called the Adagio was published in September of 2009, I believe. And it basically compared Rasagiline to placebo for the first 9 months. Then the entire group gets Rasagiline for the second 9 months of that 18-month study. And they realized that if you delay treatment, that is the placebo group, with the one comparing it to the ones who had been on Rasagiline for 1 milligram for the first 9 months, they didn't do as well. That is, if you delay treatment by 9 months, again, you may lose a function that you may not regain again. So again, pointing to the fact that you should start treatment earlier rather than later. And here's the graph of that. So this is the real drug. So this is a 18-month study, 72-week study. And they get randomized to placebo. And here they get randomized to the real drug. The scores come down. That is, they get better. But the disease does progress over time. And at this point, the ones who had been on placebo for the first 9 months, they get the real drug. They get better. But this curve never catches up with these. So if you delay treatment, and the ones compared to the ones who have been on the real drug for the entire 1.5 year period, they tend to do better at the end of the 18 months compared to the ones who had been on placebo for the first 9 months. Again, suggesting that if you delay treatment, you don't do as well. Another study, just like the L-DOPA study for Cinemet. So now we have one study with Rasagiline suggesting that MAO-B inhibitors might be helpful, one with Rasagiline, actually two with Rasagiline that I didn't mention the first one, and then the L-DOPA study itself suggesting that if you delay treatment, actually patients don't do as well. So again, the common theme that keeps coming back is that if you delay treatment, it doesn't have to be with a specific drug maybe it can be with any dopamine therapy. But if you have Parkinson's disease, even if you use a small dose of the drug, I think it's probably better for someone not to be unmedicated compared to being unmedicated in early disease. So Amantadine is an old antiviral drug. It was used in the 1960s for the influenza treatment. It does shorten the duration of the flu symptoms, at least back in the old days. It's hardly ever used for that purpose now. But again, people realize that Parkinson patients who use this drug actually did a little better. So it probably does have some symptomatic benefit in Parkinson's disease. The exact mechanism of action is not known, but it's thought to be due to blocking of this. Some people say it's a dopamine agonist, a mild one. Some say it's a reuptake inhibitor of dopamine, like let's say bupropion. But most people nowadays think that its beneficial effects are due to blocking this N-methyl D-aspartate receptor in the brain, and by doing so it helps Parkinson's symptoms. Most of the time we now use it to help alleviate dyskinesias. So I haven't found it to be too useful in Parkinson's disease in terms of treating the primary signs of Parkinson's, but I find it very useful in reducing and alleviating those fidgety, squirmy movements that people get called dyskinesias. And that's usually the way I use it. I'm going to say a few words about these three drugs, Exelon and Rasagiline and Aricept. The generic versions are rivastigmine, galantamine, and donepezil. And as you know, they belong to a class of drugs called cholinesterase inhibitors, which basically block the breakdown of acetylcholine in the brain. They've all been used initially for Alzheimer's disease, but we realize they also help Parkinson's disease. And this is the one that's FDA approved now as of 2 years ago to be used in Parkinson's disease-associated dementia, as well as dementia with Lewy bodies. So this is probably the most commonly used drug for Parkinson's disease for memory enhancing. And it also comes in a patch form. We've had the patch form for a few years now. We use the 4.6 or the 9.5 milligrams per 24-hour patch, and it's generally well tolerated. It does have some GI side effects like nausea and stomach queasiness, but that's the usual dose. A few words about Namenda, which is usually a second-line drug. It doesn't belong to the class of these three drugs. You can actually use one of these drugs together with Namenda. So it's not unusual for us to have a patient with Parkinson's disease who has dementia on the Exelon patch plus Namenda in oral form, so as add-on therapy. Hallucinations are not uncommon in more advanced Parkinson's. They are usually in the form of seeing people who aren't there, or seeing bugs or animals or kids. Sometimes they are threatening. Sometimes the person recognizes them as being unreal images and they don't react upon them, but sometimes they do, which becomes problematic. The most commonly used drug is quetiapine. Seroquel, a very small dose tends to do the job. 12.5, 25, 75, 50 milligrams a day. The maximum dose I tend to use is 100 milligrams a day, maybe slightly more, but most of the time beyond that it may not it may cause more side effects like worsening the Parkinson symptoms or too much drowsiness and so on. If worse comes to worse, you might have to use this drug, which is a drug that's actually been shown in a good randomized control study to help Parkinson's hallucinations in very small amounts. But the problem with it is that it causes bone marrow suppression. So it causes loss of white blood cell lowering and so on. And so you have to monitor the CBC, the blood count, on a regular basis, usually, I think, every week for the first few months, and then every 2 weeks thereafter. So this is a serious drug, and the chance of bone marrow suppression is 1%. So it's not negligible. And it can be lethal. For rapid eye movement sleep behavior disorder, so REM disorder is basically an abnormal presence of muscle tone when you shouldn't have it. So when you're sleeping during REM sleep is when you're dream stages, and you're supposed to be atonic. That is, your muscles need to be limp and not active. But in Parkinson's disease, this is very common. In fact, this sometimes happens years before people come down with Parkinson's. It's one of those things that people now call a sign of early Parkinson's even before the Parkinson's has started to show itself, a heralding sign of Parkinson's disease. And it has to do with acting out your dreams violently. It has to do with beating up your bed partner. People are chasing you, you're screaming, and you're acting out your dreams and punching and kicking, and it can be quite disruptive to the partners. And the patient has no recollection of doing this whatsoever when they wake up. First-line treatment is clonazepam, low dose of 0.5 milligram to 1 milligram, and melatonin, usually higher doses, 3 milligrams or higher, are effective in controlling that sleep behavior. So, one slide on coenzyme Q10. One of the sites which is now trying to duplicate that study is actually the Booth Gardner Parkinson Care Center right here at Evergreen Hospital. This study was published in late 2002, where they randomized a small number of patients, only 80 patients, to taking various doses of coenzyme Q10 or placebo. It turns out this dose, 1,200 milligrams a day, showed to be more effective in slowing down the progression of disease, at least in terms of the motor outcome, compared to being on placebo. But the study had a lot of dropouts. The study was a very short study of only 16 months and a small study of only 80 patients. So this is, again, taken with a grain of salt. But if you're going to take this medication, this supplement, I should say, over-the-counter supplement, you should take it at this dose if you can afford it. Okay? There's an ongoing study trying to duplicate this finding. They also have a larger arm of 2,400 milligrams a day of CoQ10, which one of the sites is this site. But again, you have to be de novo Parkinson's patient, not having been on anything else. So I'm done with talking about drugs and supplements. I'm going to say a few words about brain surgery for Parkinson's disease. Deep brain stimulation surgery, which is electrode placement in parts of the brain to help the signs of Parkinson's disease and reduce medication dosages. So this is the first case of this where tremor was done in 1987 in France. In Parkinson's in America, FDA approval for Parkinson's came in late 2001 or early 2002. And it basically helps the rigidity, it helps the tremor, it helps the slowness of movement. It tends not to help the gait and posture as much, especially on medication. One of the big problems is that I tell patients that the best you're going to get from DBS surgery is the best that the medicines do for you. We actually bring patients in, we do pre and post Cinemet motor testing. I videotape them to document the difference between medication off and medication on states. The bigger the difference, that is, the more you get from your Cinemet and your Parkinson medications, the more likely you are to benefit from surgery. The biggest the difference between your medication off and medication on motor scores, the more likely you are to benefit from surgery. So that's the key thing. It is not meant to improve your on-period status beyond what medicines do for you, but it is meant to make your off-period status a little bit more tolerable, less Parkinsonian off state, and less shaky, less rigid, and more mobile. But the scores that we've usually documented in the medication, well medicated on state, do not improve beyond what medicines do for you with surgery. Again, our criteria is that you're supposed to be healthy. usually under 75 years old, and not on anticoagulation, and not psychiatrically unstable, and not demented. So no serious heart, lung problems, no cancers that are not in remission. And usually we require that you have at least 3 hours of bad off time or 3 hours of bad dyskinesias per day. We give you a little diary, and we ask that you sort of tell us how many hours of off time you have per day. And this is a big problem. You have to be sort of willing to come to clinics frequently, 6, 7, 8, 9, 10 times the first year or two, because we need to get the programming right and so on. And this is huge. This is, you need to know what you're getting into. If you expect too much, you will be disappointed. If you expect the right amount, you'll be happy with surgery. So in well-selected patients, in good surgical hands, the results are very good as long as people know what they're getting into. And that basically means that you are not going to have, you're still going to have disease progression. It's not meant to be a neuroprotective surgery. It's not meant to make you go off your drugs completely. You still need to be on some drugs, and there are some adverse effects that you have to take into account before you commit to surgery. The risk of bleeding is around 2%. The risk of sort of symptomatic bleeding that makes you look like you have had a stroke is around 2% or so. Seizures are about 1 or 2%. And death is about 0.5%, so 1 in 200. Confusion perioperatively tends to be short-lived and improves well. But as I said, after surgery, we've had some people who've had trouble with phonation, that is trouble with voice volume. Sometimes that happens when your voice volume goes bad. It can, we also do detailed neuropsych testing to check memory and trouble and cognition before you have surgery done, just to make sure that you're a good candidate for it and you are cognitively and emotionally ready for the procedure. And infection, we haven't had any at the UW, but the usual infection rate is around 2 or 3%. So these are all the numbers from well-developed centers. What is it that you can expect to improve with DBS surgery? Tremor does improve. Stiffness improves, and so does bradykinesia. Dyskinesia improves in part because this surgery allows you to reduce your anti-Parkinson medication doses. And it is meant to smooth out your off and on cycling so that the off period look more like you're on, but yet again, as I said, your on period will not improve a whole lot. Other than that, you might have more on time without dyskinesias. So that's one thing that does improve. A lot of folks, when they're on, they're dyskinetic. This allows the on time to be more without dyskinesia compared to with dyskinesia. And we've had patients typically reduce their anti-Parkinson medication by about a third, 20, 30, 40%, sometimes more. But chances are you're not going to get off your medicines completely. So these are some of the things that I tell patients that they do not improve with DBS, and claiming that they do would be false advertising. So if you're falling and you have trouble with balance in the medication on state, that is not going to get better. If you have freezing of gait in the medication on state, is not going to get better. If you have trouble with thinking and memory, and I should add voice volume and trouble swallowing, they are not going to improve. Mood problems and bladder urgency and non-motor signs of Parkinson's are not going to get better with DBS surgery. I'm going to say just a few words about neurotrophic factors and some of the studies that have been done, and just to point towards the profound and powerful placebo effect of anything we do in Parkinson's disease. So a lot of open label studies looking at going back to the 1980s with adrenal cell transplantation into the brain and fetal cell transplantation and this and that. But the minute you do sham controlled studies with a lot of these neurotrophic factors and dopamine cell transplantations, many of the findings turn out to have been placebo. So there's a well-done study looking at this neurotrophic factor where they infuse this stuff surgically into the ventricles, into the brain, into the fluid-filled cavities inside our brain, and it didn't do any good and actually caused more side effects, while the open-label studies were promising. Another group of people in Bristol, England, and also in Kentucky, they infused this stuff right into the brain, right into the striatum of the brain, without it going into the ventricles. In 15 patients, again, they found great results. But the minute you do sham surgery-controlled procedures, studies, that is, you actually make a burr hole in the skull, and you don't pierce the dura to inject anything into the brain, but you actually make a burr hole to make the patient think they had something done to them. In a placebo arm, they all feel better. Their scores get better, everything is better, so they catch up with the ones who've had their real stuff done. The results become nearly identical. So it's a very powerful effect, the placebo effect in Parkinson's. There were 2 studies using embryonic dopamine cells from aborted fetuses. And both of them were sham surgery-controlled studies. Again, placebo arm, and they turned out to be negative. In fact, in one of them, there was some improvement in a small subset of young patients, but they also had runaway dyskinesias. That is, they got a little bit better. These cells do survive. At autopsy, we have autopsy on some of these folks, and they do survive, and a number of them actually do well. But the same folks who actually have improvement in their motor function, they also get these runaway dyskinesias, even though they stop the cinnamon completely. Now, some of these folks have gone to autopsy, and we have actually found pathology of Parkinson's in the implanted cells, suggesting that there may be some spillover of the pathology, of the Lewy body pathology, from the Parkinson's patient's brain into the newly implanted embryonic cells. Again, this sort of put a little damper in the enthusiasm of stem cell therapy and transplant therapy, not to mention all the socioeconomic barriers of this kind of procedure. So this was just FDA approved in mid-January. This is a scan trying to diagnose Parkinson's disease from essential tremor. It does not help differentiate between Parkinson's disease and Parkinson plus syndromes, let's say PSP or corticobasal degeneration or other Parkinson lookalike syndromes which are progressive and degenerative. But it does help to differentiate essential tremor in its early stages from Parkinson's in its early stages. This is what it's meant to be doing. So it's for many of you who have had Parkinson's for a while, this may not be applicable. This is basically for those who are diagnostic dilemmas. We don't know if they have Parkinson's or not. We don't know if they have essential tremor or not, and that would be the use of this scan. So that's the end of my talk. So how do we get questions?
Well, we take a time now, and maybe can you flip the screen over to you so that you're going to be...
So I have to do it using this thing here. There you go.
All right. So thank you again for all of your patience with regard to our technology issues. This hadn't happened before, so we apologize. But we do have a few minutes now for questions. And so what we'll do, now you get to see Dr. Sami. I don't know if you saw him before. So now as you can see him on the screen, what we'll do is I'll call out each site and ask for any questions from those locations, and we'll wait just a few moments while people respond. So when you're about to ask a question, be sure and turn your microphone on. So it should be on mute currently. If you're not asking a question, it should be on mute. When you're going to ask the question, you need to turn your mic on. Once you're done, you need to turn it back off, or we'll end up again with kind of that crazy noise, I think. So we're going to start with Anchorage and ask if we have anybody attending there. Hello, Anchorage? Any questions? Well, I see someone, but... Okay, thanks. Now we'll go to Billings, Montana. We often get quite a
Yes,
few
we
people
have a
here.
question.
Great, go
We
ahead.
were wondering about chelation. Is that something that is a recommended way of dealing with Parkinson's?
So my personal answer would be no. We have no, I mean, I'm a big believer in big randomized controlled studies. It's very hard to do them in a lot of cases. You know, we don't have great randomized studies with bromocriptine, or even levodopa before the L-DOPA study was done. But we've been using it because of experience. But I haven't found that I have had folks who have had chelation and haven't found them to be greatly improved. And I'm not sure what the underlying biology would be. What are you chelating? We know that there is some abnormal iron deposition in parts of the brain in Parkinson's disease, but chelating metals or substances from the serum has little effect on what happens in the brain itself. So my answer would be no.
Okay. Any other questions, Billings?
Subject, there's an article here that mentions Purdue University has discovered a treatment to reverse Parkinson's symptoms, and that using chelation, that it picks up the manganese out of the blood when it picks up all the other heavy metals, and they said some are still Parkinson's free and after 17 years.
So manganese toxicity is a different disease than Parkinson's disease. So the idea of manganese exposure causing Parkinson's is actually very controversial. But manganese itself can cause a Parkinson look-alike disease called neuromanganism, which has Parkinsonism as part of its overall clinical picture. So is it possible that the folks in that study, Indiana, are not Parkinson folks, are actually manganese intoxicated folks? In that setting, I can imagine chelation improving it. It would be nice to see the numbers. I haven't read that study, but if you don't mind, you can send me the link, and my email is public information, so I can look at the number of patients that were studied and what outcome measures measured, and whether people who were actually measuring them were blinded. Was this a blinded study? As I said, the placebo effect is very powerful in Parkinson's because we as physicians are highly suggestible, and so are our patients. So a lot of the open label studies are profoundly positive. Only when you do a randomized controlled blinded study with blinded raters, the study turns out to be negative. So.
Okay, so
80 patients have been treated so far.
And is it a blinded study or open label study?
It doesn't say here.
I have to look it up. I have to look at the study because I'm not familiar with that, so I have to educate myself a bit more before answering that question.
Thank you very much.
Okay. All right, Billings, any other questions? Okay, thanks very much. We'll move on to Clarkston.
Yes, we have a couple questions. What are the symptoms of carbidopa crossing the blood-brain barrier? Then I have another question.
So basically, carbidopa crossing the blood-brain barrier will reduce the efficacy of levodopa. That's basically, if you give too much carbidopa, if it does cross, it is not meant to cross the blood-brain barrier, but at high doses it could, and that's why we have the 1:10 ratio of carbidopa-levodopa. But it basically makes the cinnamate not work as well. That's pretty much it. Yeah.
Thank you. Question number 2, what do you think of the medication called Zelapar?
So I didn't discuss Zelapar because it's so hardly ever used. Zelapar is orally disintegrating selegiline, also called Zetas selegiline. It comes in 1.25 and 2.5 milligram dosing, and it is actually a drug. It's a form of selegiline, FDA approved for more advanced Parkinson's disease, and it gets absorbed through your oral mucosa. It actually does not need to go through the gut to be absorbed, and it bypasses the liver, so it's not metabolized by the liver, and it doesn't have the amphetamine byproducts that regular selegiline does. We hardly ever use it. At the VA, we have no access to it. But it came out around the same time as Azilect, Rasagiline did, to compete with it, but it hasn't kept up, in part because it's made by a very small company, and they haven't really caught popularity. I think I have a few people on it, to be honest with you, but not that many, maybe 5.
Okay, one more thing. I think I know what you mean. There's a difference between the open label study and the blind study, but could you explain that a little more thoroughly, please?
A blinded study is where both the doctor and the patients, a double-blind study. So that means you randomize a group of patients randomly in a large sample, usually in the order of 300 or 400. Most of the randomized control studies in Parkinson's are in the order of 300 or 400 patients. Now, the Adagio study was almost 1,200 patients. It was a very well done study because it has a very large number of patients. And you randomized patients to get the real treatment versus the placebo treatment without knowing what they're getting. And it has to be such that they actually know, they actually think they're getting it. So for chelation, for example, you would have to put IV lines in them and imagine you tell them that you're being chelated while they're not being chelated. So you have to have some kind of sham procedure. And the doctor who sees them also has to be blinded, because we are also very biased. We would like to think our patients are getting better with what we would like them to get better with. So we also may give them lower scores for their motor scores if we know they've gotten the real drug versus the placebo. So it has to be blinded in both ways. Both the patients have to think they're getting the real drug in the placebo arm, and the doctors should not know which arm these patients were randomized to. So that's a good double-blind randomized control study. An open-label study is when both the patient and their family members and the doctors and the nurses, they all know who got what. So it's very easy to make yourself believe that somebody is getting better by giving them lower scores when you know they're getting this drug or this procedure or that procedure. Yeah.
Thank you. That's the end for Clarkston. This was a very good presentation. Thank you very much.
Thank you.
Thank you.
Where is that? Is that in
Washington? Clarkston, are you in Washington? Yes.
Yes,
All right,
we
Coeur
are.
d'Alene?
Okay.
Oh, thanks. Coeur d'Alene, Idaho? Do we have anyone there? Okay, let's try Dayton. We have Dayton, Washington. It's really a small place. Okay.
We have no questions. Thank you.
Thank you for checking in. All right, next would be Kennewick.
Kennewick's here.
Any questions?
Yes, I've got a couple of questions.
Okay.
One is you referred to, and I'll have to use your language, referred to the little round yellow pills versus the blue oblong pills. Is there ever a situation where one should take just the oblong blue pills, or should one always take a combination of blue and yellow?
You can take one or the other or both. It's not so the yellow round pills are the 25/100 carbidopa levodopa pills, and the purple gray oval-shaped pills are the controlled release 50/200 pills usually. And for people who want to take their medicines, so one problem with controlled release pills is that they don't have the same predictable absorption that the immediate release pills have. But when they do get well absorbed, and some people do very well with them, they last longer. So it's not on. So half my patients take one, half of them take the other, and there are some of them actually take both. It's not unusual for us to have a patient take both formulations of regular release and controlled release carbidopa levodopa. They can be used in combination.
Okay, one other question. What can you tell me about vitamin B6?
So vitamin B6, too much vitamin B6 might interfere with the actions of levodopa. And I'm trying to remember what it might be. I think it might have to do with the crossing of the blood-brain barrier. And Lori Mishley, our naturopathic colleague, taught me this once, but I forget the answer to that question. But too much vitamin B6, which is pyridoxine, might actually interfere with levodopa's action in terms of treating Parkinson's disease. Now, most vitamin B complex pills do not have huge amounts of B6 unless you take a lot of B6 on your own, which we don't recommend anyways, because it can give you neuropathy. It can give you nerve damage at huge amounts. A lot of folks take large amounts of B6 when they're taking anti-tuberculosis medicines. So,
okay, thank you.
Because one of the drugs for that lowers your B6 levels.
Any other questions from Kennewick?
No, I think that's all for.
Okay,
Thank
thanks
you.
very much. Kirkland, the live audience.
Yes.
I'm not familiar with what you were talking about with another location about chelation.
So I'll have to look that up.
Well, what
No,
is it?
chelation is removal of substances, usually metals from your blood. So it's a metal removal. So we do it, let's say, for Wilson's disease, or they do it for metal intoxications and things like that. So chelation therapy.
Any other questions from Kirkland? Okay. Miles City in Montana. They usually get a pretty good crowd. Nothing from Miles City? Okay, how about Moses Lake in Washington? These guys are definitely off. No? Okay. We're down to Pullman. Any questions? All right, how about Ritzville?
Where's that? Pendleton, Washington? Mm-hmm.
Pendleton's around.
Ritzville?
You didn't say it loud enough.
That's probably the problem.
Pelton has a question.
Oh, okay, Pendleton. Go ahead.
They're still there.
Where'd they all come from? Okay, you need to turn on your microphone.
Here, don't touch it now.
Okay.
Okay, go ahead.
We'd like to know when a patient what are the indications for starting Azilect on a patient?
So Azilect is FDA approved for both early disease and more advanced disease. There are 4 large randomized controlled studies for Rasagiline, and it's one of the better studied drugs in Parkinson's disease. So I tend to use it in the novel Parkinson patient, the newly diagnosed Parkinson patient who's not taking anything else as first-line drug, if they can afford it. If they can't, I tend to start Rasagiline. So it's a very expensive drug, and insurances do cover it. But for folks who have high copay, they may not be able to afford it. But it's one of my favorite drugs to start in early Parkinson's disease before starting anything else. Usually, I start people on Azilect, 1 milligram once daily, and I tell them that if you don't feel any benefit from this medication, do not give up. It takes 8 to 12 weeks for it to show any benefits. Even if you don't, chances are that if you take the next line drug, let's say Mirapex ER or Requip XL once daily, it'll keep us from having to increase the dose of that drug too high. And even if the time comes for you to take carbidopa, levodopa, it'll probably allow us to use a smaller amount of Sinemet. The next situation is as add-on therapy. So there are studies, there's one big study called Largo, which has compared Rasagiline, which is Azilect, to entacapone, which is Comtan, as add-on therapy in Parkinson's disease, suggesting that it's as effective as entacapone in reducing off time and increasing on time in Parkinson's patients who have endodose wearing off and motor fluctuations. So it can be used in any stage of Parkinson's disease, really, both early and more advanced.
Thank you. No more questions.
All right, thank you very much. Did I say Ritz? Bill? I did say that? Okay. Sandpoint, Idaho. Or did we take them off? Okay, I want to get to Spokane because I know we usually have quite a few people in Spokane. Any questions from Spokane?
Didn't change to that site.
I guess we don't have any questions.
Okay, well, Tanasket?
Tanaska has no questions. It was a very good program. Thank you.
Okay, thank you for being there. Thank you for checking in. And finally, Walla Walla?
Yes, I have a question. I'm
Okay.
on Cinnamate. I take it about every 3 hours, the little yellow pill. I don't take it during the night. However, I have to get up 2 or 3 times and find it very difficult getting back and forth. Would it be a good idea to take it during the night too?
You can, or you can use a longer acting carbidopa, levodopa, 50/200 at bedtime. It might last a bit longer. So there are people who use a bedtime dose of the longer acting controlled release carbidopa, levodopa to help them stay more mobile so they can roll over in bed more easily and make it to the bathroom. And there are people who take a regular release, the 25/100 yellow pills, in the middle of the night to be able to fall back asleep or be more mobile so they can go to the bathroom. So the answer is yes, you may.
Okay, another question from Walla Walla?
Yes. I know that a lot of people don't go for glucosamine. I took it for a long time and felt it helped my legs. Then I stopped because I was on so many other medications, and it seems my legs got worse. Now, it might just have been my imagination, but do you want to say anything about glucosamine?
Yeah, I don't know if that was placebo effect or not, but glucosamine with or without chondroitin is usually used for arthritis and joint pain, and a lot of my patients are on it and they swear by it. A lot of my patients are on it and they have no idea if it helps them or not. But to be honest with you, I'm not sure. It shouldn't interfere with your Parkinson drugs, so that should not be a concern for you to not take it. If you think it helped you and you can afford it, then you may start taking it again.
Okay.
Thank you.
You're welcome. Thank you for your questions. Well, I think that
we have a question.
This
Hi,
is
we're
Clark's.
We're in Port Townsend, and we got skipped, and we have a question for you.
Not listed. Sure, go ahead, Port Townsend.
We have a general question, wondering if there's a copy of this presentation or past presentations that are available for people in our group who have missed them or would like to review them.
There is a CD DVD that's produced of each of these presentations, and you need to contact the Parkinson's Resources Group out of Spokane. They're the ones that put that together, so you can contact them directly to get that.
Great. Thank you very much. Yep.
You're welcome. Sorry for skipping you.
And this is Clarkston, Washington, and we have one more question, please.
All right.
What happened to the surgical procedures called ventral thalamotomy, stereotactic destruction of basal ganglia?
Yeah, so those are still being done. In fact, those were the first procedures that were done for Parkinson's disease and for tremor. And there are rare instances where a thalamotomy might actually be the procedure of choice. So this is a procedure where you burn a 6-millimeter hole, you destroy tissue in the thalamus. And you can do it via gamma knife, which I don't recommend because I don't think we know exactly what you're burning and destroying. Or you can actually do it using an open surgery. You make a burr hole and you go in and you localize the target and you destroy tissue. So it's been done for the last 65 years or so. It goes back to the 1940s. Both thalamotomy and pallidotomy have diminished in frequency of being done because they cause permanent lesioning of a target of the size of a very small pea, 6 or 7 millimeters in size, and it's irreversible. So when you destroy that tissue, you've destroyed that tissue and there's no going back. With deep brain stimulation surgery, it is thought, it may not be true, but it is thought that you are sort of mimicking the actions of a lesioning, the actions of destroying tissue by zapping those targets at very high frequency electrically. without destroying the tissue of the area that you're stimulating. And you can adjust and you can sculpt the degree to which you stimulate those targets by variable frequencies and voltages and power of stimulation, so that you can actually adjust it and vary it to your advantage. So if you happen to be in the wrong location,
would you be able to take these Saturday for the regular meeting?
This coming Saturday.
Yeah.
I think someone has their mic open, sorry.
So, as I said, so DBS is basically an adjustable way of doing the same thing. If you happen to be in the wrong location, you can actually go up and down and program the stimulator by using different contact points. When you stick an electrode and leave it in the brain and you leave it in place, there are 4 contact points covering an area of, let's say, half an inch, and they're separated by about less than 1/4 of an inch from one another. It's a small amount. So you can actually use a contact point that is the better one to get the result you want. That's the advantage of DBS. But especially in developing countries, thalamotomies are still being done. Pallidotomies are still being done, yes.
All right, so we have run over by a few minutes today, again, due to our technology issues, but truly that was an excellent presentation, Dr. Sami. We really appreciate it. I think that was a huge amount of information that you were able to cover under duress. And so again, this program and others are available by CD or DVD through the Parkinson's Resources Group. And that takes care of today's telehealth presentation. We'll be back in May to do another program, and I don't have that in front of me, but it's on our website, Northwest Parkinson's Foundation, as well as Parkinson's Resource. So thanks again for coming.
Thank you.
Thank you all for bearing with us.